if you start it early. Anyone wants to take first?
Maybe I start to answer first. We know that in atopic eczema, we always look at more than BSA. We also look at the age, how bad the disease impact on their family members, as well as the child school performance. All need to be considered before you decide. Of course, at the same time, you need to make sure that you already optimize the topical treatment. Let's say all this already taken into consideration. If you monitor the patient after another 6 months, it's still more than 10%. I do consider offering something beyond topical, which could be any form of conventional or the new systemic treatment. How about you, Dr. Yang?
I think I would not only to take the BSA as considerations. If the BSA only less than 10%, but it has a very sleep quality affected, and their family is also severely affected by the disease of the children's. And one other thing is that if the skin symptoms just occurred over the functional area like head and neck, and hand and feet, that we should take a more aggressive treatment for them because they are just very severely affected the whole quality of the life. So I would take other parts for my first consideration, and itch would be the most profound troublesome symptoms for them. If they have very last BSA skin symptoms, but suffer from very severe itch, that would definitely affect it. The sleep quality would definitely affect very severely and influence his school performance. It's just influence too much. So I would take other parts for considerations for that. And I believe that if their disease if the relapse very frequently, that have every month that have a disease relapse, that we should take the relapse of the frequency of the relapse of disease as very important consideration as well. Although that he has less than BSA, that he has relapsed every month, of course we should treat them more aggressively and try to help them to get although it might not very easy to get remissions, but we know that we can treat them well, that we have more chance to become some like outgrowth of the disease, because as we know that maybe they can have more chances for the restoration of their skin barrier, and with the restoration of skin barriers that will help them to influence the immunology profile, just like the previous studies has shown that the systemic immunology profile may be also improved. Yes, just like it's my opinion.
And I totally agree. I fully agree. But in our busy practice, sometimes we don't have much time to spend for every single patient. So I feel that if you use a validated scoring system like the POEM, which is a patient-oriented eczema measurement score, is very simple. You can ask others to ask the patient and fill up. So it gives a reflection of the patient's symptoms for the past 1 week, not just at the moment that you see the patient in the clinic. So that will help you in your practice and to assess whether they need systemic treatment along the way.
Yeah, I think we need to lower down the threshold now, because I do agree before 2017, we only have MTX, cyclosporin, azathioprine. All these are almost in the same category with oncology drug. Indeed, many years ago, it's really a very challenging to initiate systemic treatment for young kids. Even though they have severe atopic eczema, it took us many follow-ups to convince the parents, not to mention about frequent blood taking and not certain about the long-term prognosis because of the medications. Now with a much more safer medication, and you share with us that 30 over cases, and maybe you can share with us also about many parents worry about MACE, the major adverse cardiovascular event, malignancy, thromboembolism. We do know that these are usually for older patients, but how about in pediatric case? Some of the parents like to go to TikTok and Google and say, I saw this medication is related to this major event. How do you counsel them?
Because there is a long-term safety profile, right now. And actually, as just taking the considerations for the malignancy that from the latest meta-analysis of the JAK inhibitors on atopic dermatitis, and actually that is there is no, especially in the baricitinib drug, there is no higher rate of malignancy rate comparing with the same reference group of the patients, such as alopecia areata, rheumatoid arthritis, and also atopic dermatitis. Actually, there are no higher rates of malignancy, the incidence of the malignancy. And I think if we take the whole JAK inhibitors, that I think the malignancy rate we just we catch up are all from the studies of most are from the study from the tofacitinib, and with the cases in rheumatic arthritis, and most of the cases are older patients that, and we believe that with the better treatment of the patients, if we weigh the benefit and risk, I think the benefit is overweight by the risk. So yeah.
About Dr. Ng?
Yeah, actually, the other way to counsel them is you can tell them to Google up about ibuprofen. Ibuprofen that's used so commonly in children also has a black box warning by FDA of increased risk of cardiovascular, increased risk of bleeding, etc. So I think that's one
people
way.
look at black box warning in different way. In fact, they say only prednisolone does not have black box warning. Yeah, MTX had black box warning, cyclosporine all have black box warning. And for unknown reason, maybe the society already put a black box warning on prednisolone, so you have FDA is a bit lazy to label it black box warning.
That's very enlightening, doctor.
Yeah.
It's really good.
Yeah.
It means black box warning actually exists for even sort of like the cancer treatment.
Yeah.
And we are also actively using it. And now that we have a study that shows that the drug is safe in these patients, then maybe we need to counsel more and educate our patients a bit more as well. Right. I think thank you, Dr. Leong, Dr. Yang, and Dr. Ng for that very engaging panel discussion. I think it definitely has helped me put a new lens towards atopic dermatitis and uncover new insights to advancing patient care. So before we go for a quick 15-minute break, we here at Zakipi Therapeutics would like to understand if this session has been beneficial for you. So right now on your screen and also in the chat box, what you will see is there is a link to a Slido website, which will allow you to answer several questions that will help us to design our events and our narratives in the future for our future events for our doctors. So if you can, it will take you less than 5 minutes because it's only 5 questions. So what you can do is there are a few ways you can access it. There is a link in the chat box. You can also log on to slido.com and key in the number 3411435. And additionally, there's a QR code on your screen as well. You can scan with your phone. So there's multiple ways to access it. We just really do appreciate that feedback from you. So while you're filling up that feedback form, we're going to take a 15-minute break and we'll see you back here shortly. So stay tuned. Online, can the online audience hear me? So I think I'll just announce a little bit for our physical attendees. There is coffee and tea outside. I think there's still a little bit of refreshments out of the hall. If you do need something to grab a cuppa, get some snacks, you can go out and get it as well while we'll proceed on to our psoriasis session.
sunshine. You are the ocean to me. You are the sunshine. You are the ocean to me. You are the ocean to me. You are the sunshine. You are the ocean to me.
So hi there everyone, good evening and welcome back everyone. I think especially to our physical attendees, hope you actually grab a cuppa and you're able to recharge. And for our online attendees, I also hope you managed to go to the toilet, get a bit of a break, and you're ready for our second session. So in the last session, we learned a lot about atopic dermatitis and specifically in the pediatric population. And this time around, we're going to think about another inflammatory skin disease. And specifically, we're going to talk about psoriasis and psoriatic disease to a certain extent, because psoriasis itself just goes beyond the skin. It can also attack the joints and cause permanent irreversible damage to our joints. So right here, I'm going to introduce our moderator for the psoriasis session. So she is Dr. Sherin Cheng, who is a consultant rheumatologist who's currently practicing in Hospital Selayang. And besides just being a doctor or rheumatologist in Hospital Selayang, she's also very active in the Malaysian Society of Rheumatology. She currently serves as the vice president and she looks into events in order to enhance and upskill our future generation of rheumatologists. So now let's roll out the red carpet and join me in giving a resounding welcome to Dr. Sherin Cheng.
Thank you very much, Jared, for that glowing introduction. It's a real pleasure to be here amongst y'all, dermatology colleagues. I mean, it's a great honor for me to be learning and sharing with y'all here. And I hope that this psoriasis session will be a very interesting one, I hope, and hope that we will get some new insights. So to kick off the session, we will invite Dr. Moniza Akmal Ahmad Kamil, whom I'm sure it's no stranger to y'all. As I was saying, it's so strange for me, an outsider, to be introducing your own colleague. But anyway, Dr. Moniza is a consultant dermatologist at Hospital Kuala Lumpur, and she will be delivering her lecture about psoriasis. I think the topic is more than the skin, right? Yes. Dr. Moniza.
Assalamualaikum warahmatullahi wabarakatuh and very good evening. Thank you, Dr. Shireen, for the kind introduction. Good evening, everyone. So today I would like to thank ZP Therapeutics for inviting me to share with you some cases on psoriasis that we have seen in the clinic. Okay, my topic today is same psoriasis, different patient needs. Okay, let's go to the case number 1. Okay, this is my disclosure for today. Okay, my case number 1 would be Madam F. She is a middle-aged lady. She presented to us back then in 2007. She was only 38 at that point of time, presented with scaly plaques on the scalp and a little bit of nail changes. The BSA was about 1 to 2%, limited to the scalp. So this patient initially presented with a scalp psoriasis, which was maintained throughout the years for 4 to 6 monthly follow-up. However, in 2013, she had worsening of plaque psoriasis. Now involved the trunk and limbs. Okay, so BSA from 1 to 2% became 15%. And at this point of time, she also complained of lower back pain and a bit of stiffness. X-ray showed bilateral and symmetrical sacroiliac changes, which could represent psoriatic arthritis. Right? So what do we do next? August 2013, methotrexate was started. It was started up to 15 milligram weekly. However, she couldn't tolerate much higher dose because of the GI side effect. Okay, this actually happens quite a lot in the practice. Okay, sometimes we need to modify the dosing according to the patient's tolerability. There was not much resolution with methotrexate actually. Okay, and the year after, we tried phototherapy. She had narrowband UVB for 37 sessions in total. Unfortunately, that didn't work for her as well. March 2015, we commenced back on methotrexate. And after about a year, not much improvement, changed to acitretin. At that point of time, BSA was already 40%. Okay. Unable to usually for acitretin, we give about 0.4 to 0.6 milligram per kg body weight, but she couldn't tolerate more than 30 because of the dryness, scaliness, and also the heaty feeling when you have acitretin. Okay. So we tried to the next conventional treatment, which is your cyclosporine. At that point of time, the BSA has already become 70%. Okay. Still having back pain with stiffness, although this point of time, the X-ray reported as normal. So, 2020, she was started on secukinumab, an interleukin-17 inhibitor. At week 4, she already achieved PASI 50, week 8 achieved PASI 75, and week 12 achieved PASI 90, with a BSA of around 1 to 2%. And while on secukinumab, no joint pain was documented. Okay. However, okay, the event turned out to be she had COVID booster dose in February 2020, causing the flare of psoriasis. Remember when she had almost clear skin? Now the psoriasis involved the trunk and limbs and scalp and nails. BSA is about 15% at this point of time. So the psoriasis kept on worsen despite on regular dosing secukinumab, and at certain point we tried to reduce the interval. So in reality, in the dosing recommendation, it's actually given 4 weekly. We even tried to give 3 weekly and 2 weekly. We in fact tried to add on methotrexate with secukinumab on board. However, that doesn't work. Okay, so this patient has been labeled secondary failure to secukinumab. Then, because of that, we changed the medication to guselkumab. She was given up to 5 doses of guselkumab unfortunately for her, it doesn't look well. So early this year, the body surface area involvement worsened, achieved about 70% at that point of time. And this was how she looked like in early this year. It was erythrodermic. Okay, in erythrodermic patients mean the PSA involved is more than 80%. So we can see from the picture here, the whole body is red except a little bit of the feet, a little bit on the lower thigh, lower buttock area, the face, the scalp, everywhere is red. So this patient now is having erythrodermic psoriasis. Okay, what we have here is actually a middle-aged lady, long-standing psoriasis, which started initially as a scalp involvement alone, okay, progresses into all these progresses and doesn't